What is rehab or rehabilitation? My name is Fred Bagares, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. All right, gotta love this topic. Good old Dr. Google. Obviously, with the advent of the internet, there's definitely a lot of pros, also some cons, but particularly when it comes to the medical literature and the topic of self-diagnosis, Dr. Google is here to stay. So rather than think of it as a negative, I like to use it as a tool to help understand my patients so ultimately I can help them better. In the beginning, initially did not like it at all. As a young clinician, it was rather upsetting to know that people would look up their own diagnoses and be very convinced that they have diagnosed themselves correctly. It's hard for me to describe the level of anger I think a lot of physicians feel about it, but use this analogy. It's like when someone who doesn't have any kids tells a parent that it's not that hard. It's somewhere in that order. But as I got older and more experienced, I actually started to encourage people to start using Dr. Google because number one, if I said don't use it, they're going to use it anyways. But number two, I started to learn from patients how they view their body and what diseases they were most concerned about. It's interesting. Imagine two patients that have the exact same symptoms. Let's say back pain, leg weakness, and numbness. The first patient punches that into Dr. Google, and they come up with very common diagnoses, and that's good. That's a good place to start. But then let's say the second patient has the exact same symptoms, and they come in with their differential, and it is kind of the scariest stuff out there. And to me, it was kind of amazing that two patients with the exact same symptoms can come up with completely different diagnoses. And it made me think about how is it possible that they had such very different lists? And I think that's kind of the in-between stuff that you don't really find in medical textbooks. There's a lot of fear, anxiety, maybe false information or presumptions about their condition that changes what actually gets spit out. That would be a pretty cool experiment to see if I could sit with a patient and watch how they look up their own history and come up with a diagnosis. I think that would actually give me a lot of insight and would be really beneficial to how I would approach this particular person. I would say that the top reasons why people will see me after consulting with Dr. Google is number one, they have found a diagnosis that they like and they would like affirmation. Another reason is that they are overwhelmed. They have opened up Pandora's box. There is a million articles, links, and they need someone to help make sense of the information that they found. The last reason I believe is fear. Some people will find a diagnosis that they think that they have, and they are very, very worried about it. And they will come to me at that point to try and put them at ease. And this last type of patient, it can be a little bit tricky because they will often, I find, not tell me right off the bat, what they are concerned about, but they will, kind of feed me these descriptors of their worst fear diagnosis and see if I come to the same conclusion. I have learned to pay attention to that. So once I start to hear them kind of take that tone or start talking that way, I feel like I kind of know how to approach them and how to put them at ease because I've now identified, essentially where they're coming from. I kind of started looking at it as a starting point of where to start our discussion, where to build our relationship off of. With time and practice, and I just didn't really find it very useful to try and debate with patients regarding their diagnoses. I kind of just sidestep it and just started to focus on what their concerns are and what we can do. Overall, Dr. Google, I have started to see the advantages of it. However, there are the obvious downsides to it that I actually wonder if patients realize, or even clinicians. Some clinicians who are still learning. I didn't have Google as a source of medical education coming up, but I know that it's pretty much the number one resource for most people. Some of the cautions with Dr. Google is that the Google results are highly dependent on search engine optimization. So results typically satisfy the quote unquote the algorithm, or someone has paid Google ads for a higher ranking. And that's not necessarily the best way to try and diagnose or learn medicine, is based off of essentially Google rankings, because Google rankings are not really based off of reliability and validity or truth. They're just results that pop up. So at the same time, these results are quite powerful because for someone who is not medically trained, it has a very, whatever is in the first 5 results will likely be top diagnoses that they believe that they have, and down the rabbit hole that they go. However, it's not necessarily a bad thing that they have a baseline of information, because given the presentation of symptoms, the top 5 is probably not a bad place to start. And I would rather have someone come in, with a somewhat of an understanding, because it can be a lot to squeeze into a visit. Fortunately, in my practice, I typically spend somewhere between 45 to 90 minutes with my patients, so I have time to educate them. But for those of you that are practicing in like that 7 to 10 minute window, it's a good idea, for them to have some information. That way you can focus on other aspects of the visit. And to be honest, can you really blame them if you have a really very short visit and they want to have a fruitful visit, but they also know that you have limited time to educate them? It's not necessarily a bad idea for them to start somewhere, and oftentimes that somewhere is online. From a clinician standpoint, I encourage you guys to essentially talk to your patients, find out what they think they have, what diagnoses they came up with, and start from there. I think a lot easier to meet people where they're at versus try to drag them along in a direction that they don't want to go, or they feel like they are in the right. It can be very difficult, and I'm not saying that you shouldn't correct them, but particularly the folks that are in a pretty packed clinic, it's hard to convince people and earn their trust, or even make them open to new options in a short 7-minute visit. So, I think overall, try not to shoot down their ideas. That's probably the best advice I can give you, is that even though it might sound, you might wildly disagree with them, and sometimes patients can come in very, very convinced that they have figured it out. I think sometimes you have to just take the higher road and just treat them, because ultimately a majority of people are coming there because they want help. Again, due to the non urgent nature of most musculoskeletal disorders, we do have a little bit more latitude in following patients with their diagnoses. So a great example is lumbopelvic pain. Lumbopelvic pain is quite vague. You could be talking about muscle-related pain, SI joint, piriformis, facet, referred radicular pain, peripheral nerve entrapments, the sciatic nerve itself. So it's, if a patient comes to me and says piriformis syndrome and it's lumbopelvic pain, it's probably more right than it is wrong. At some point, you have to ask yourself, did I really just make a distinction that didn't really have a major difference? Or what was the gain of making that distinction to the patient other than, challenging them or, just trying to stroke my own ego? On top of that, a lot of the treatment is kind of applies to all these diagnoses. So a lot of times it's physical therapy, over-the-counter medication, sometimes injections. But from a movement and a therapy standpoint, exercises, there's so much overlap with these various conditions. Even from a PT standpoint, I think that they would agree that starting a movement program is going to be the key, because even if they start off with one diagnosis, they can always shift. So I don't really find it very useful if I'm dealing with lumbopelvic pain and I think it's a disc herniation and the patient is convinced that it's a piriformis problem. We can both be right and start there. It's not a life or death situation. I just think that we have to essentially work with our patients. I think long are the days where they take our word as gospel. How patients view us now is that, our information is just as good as Dr. Google. So I really hate to say it that way, but I think it's true. Our information and our education is really weighted in the same category as eventually finding stuff on their own. And that's just kind of the way that it is. I don't think it's, again, very useful to try and force people to believe our information. I think people will believe us if they trust us and if we empower them and we try to, we make them feel heard, and ultimately we try to help them. Because at the end of the day, if the diagnosis doesn't necessarily make the biggest difference, it's whether or not the patient is feeling better or not. That is what counts. Even on paper, I tend to sometimes diagnose two separate conditions, and in my description, I'll kind of lean more to one versus the other. That way, I can kind of keep my mind open. It's it's not uncommon. Obviously, I can't claim that I'm right all the time. So if a patient brings in an idea, hey, I'm open to it. I think I would be fairly ignorant to assume that I know everything, and also to assume that I don't ever make mistakes. And also, don't assume I would be ignorant to the fact that sometimes patients are right and I'm wrong. I just wanted to kind of bring this up. Again, Dr. Google is here to stay, particularly with AI coming. These language models and are just getting better and better. So we're going to start to see probably some pretty good diagnoses coming across. So as clinicians, as human clinicians, I guess maybe I should say, we need to be ready to deal with this kind of information, deal with the patients that are looking for help, that are learning from these resources. So I hope this was helpful for you guys. Try to keep an open mind, meet the patients where they're at. It doesn't make a difference where they get their information as long as they trust you. Thanks again. Thank you for listening to the Talking Rehab Podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.